For those of you who don't know me, my name's Katrina Billick. I'm a Labor Senator from Tasmania, and I'm one of the co-chairs of the Parliamentary Friends of Ends of Life group. The other beautiful person that co-chairs with me is Nola Marino, who I think's been delayed, but will obviously get here if she can. Nola and I often do what we call tag teams. If one has to run away when the bells ring, the other one takes over. So it's a good relationship. We've been doing it for many years now, and can I say I thoroughly enjoy working with Nola too, and it's nice to be working with someone from the other side of politics on such an issue that really should be and is bipartisan. I'd like to begin by acknowledging the traditional owners on the land on which we meet and pay my respects to their elders both past and present. We've got a number of people to acknowledge today. I've mentioned Nola Marino, my co-convener with Parliamentary Friends of Ends of Life group, Mr Julian Hill, MP member for Bruce, Emma McBride, MP member for Dobell, Andrew Lee, MP member for Fenner. Now, some of these people will be coming and going through the day. I'll explain why in a minute. Ms Joanne Ryan, MP member for Layla, Mike Freelander, MP member for Macarthur, Susan Templeman, MP member for Macquarie, the Honourable Kevin Andrews, MP member for Menzies, Senator Chris Kettup, Senator for Queensland, Senator Murray Watt, Senator for Queensland, Senator Sterling Griff, Senator for South Australia, Mr Tim Storer, Senator for South Australia. I know the Honourable Julie Collins, MP, Shadow Minister for Ageing and Mental Health, is going to join us. I actually left a meeting early with her, but she will be here. And Senator Helen Polly, my colleague, one of my Senate colleagues from Tasmania. Now, what will happen with any of those people will be, if the bells ring, you'll see a red light and a green light, either or both, light up on that clock over there. That means people, members and or senators, will have to go to a vote. So unless they're like me and manage to be paired out for the whole time, they will have to leave today, but I'm sure they'll come back if they can. We've also got some great invited speakers today. We've got Dr Stephen King, the Commissioner of the Productivity Commission, Dr Stephen Duckett, Health Program Director from the Grattan Institute, Professor Mike Woods, Professor UTS Business School Centre for Health Economics Research, and Associate Professor Anna Barker, Head of Member Health Innovations Medibank. So please welcome us. Please welcome those, but also what we've got today is, and I nearly forgot this, is a live stream. So we've got people joining us on via the live stream on Palliative Care Australia's website. And I think we've got a slide about that there. Is that right, Liz? Yep. Great. So I've told you what happens when the bells ring. If we could just welcome everyone, but especially our guest speakers, and thank you. We do truly appreciate you all giving up your very valuable time to come and talk to us. And it's now my great pleasure to introduce or to welcome Dr Jane Fisher, who's the President of Palliative Care Australia. So, Jane? Oh, there you are. Haven't even seen you this morning yet. This afternoon. Welcome. Lovely to see you.
So, welcome. I too firstly would like to acknowledge the Ngunnawal people, the traditional custodians of this land on which we're meeting, and pay respect to their elders, both past and present, and extend this respect to any Aboriginal or Torres Strait Islander peoples in attendance with us today. This is our third Parliamentary Friends End of Life group luncheon for 2018, and it's wonderful to see so many of you here, and I also extend that welcome to members of Parliament, to our speakers, and to all of you as special guests, with a particular thanks to Katrina and Nola, who are co-conveners for these events. As we all know, that there is important debate happening in the upper house this week. And I think for us here at Palliative Care Australia, this is a really great opportunity for us to raise awareness and to talk about the need for palliative care. We know that there's an increasing need for palliative care with the ageing of our population, the growth in chronic disease. We have an interface that we're seeing between the health sectors, aged care, disability, yet they are all systems with different funding models. And there are still, unfortunately, many gaps in the system for those people who are actually wanting to access good quality care at the end of life. I think we're also living in a time of and seeing major health reforms across the system, and yet palliative care has not had the focus on the development of a funding and policy framework that's going to set us up for the future. I think this is a critical issue for us as a community, and I think governments should fund palliative care to the point that its absence can't contribute to the demand for voluntary assisted dying. Today, we've got a range of experienced professionals speaking on our theme, palliative care, reform, funding and data. And it gives me great pleasure to introduce our first speaker, Dr. Stephen King. Stephen is a Commissioner at Australia's Productivity Commission and an adjunct professor at Monash University. He was one of the two commissioners who led the Productivity Commission's 2017 inquiry into reforms to human services. And a key part of this was analysing end-of-life care in Australia and recommending ways to improve care. So he's going to talk to us about reform to human services and caring for people at end of life. Welcome.
Okay, thank you, Jane. In October last year, the Productivity Commission completed its report into introducing competition and informed user choice in human services. Now, the terms of reference for that inquiry didn't state that we should look at end-of-life care. However, early in our investigation, it became very clear to us that end-of-life care is a key area of concern. It's an area where Australians too often have highly limited choice and are unable to meet their healthcare preferences. So the problem is not that end-of-life care that is being provided was or is poor. In fact, the opposite's true. We found that the quality of care being provided, where it's available, is often excellent. However, the problem is that too many people are missing out on the care that would best meet their circumstances and their preferences at the end of life. Now, this problem is likely to grow over time. Annual number of deaths in Australia are predicted to double in the next 40 years as the population ages. Further, the end-of-life care needs of Australians are changing. A smaller proportion of people die suddenly or die of illnesses with a relatively predictable trajectory, such as cancer. As one of the submissions to us noted, more people are experiencing a prolonged period of disability, frailty and illness, and then dying with unpredictable timing from a predictably fatal chronic disease. So end-of-life care became one of the 6 areas that we focused on in our inquiry. The inquiry resulted in a series of recommendations, including some for end-of-life care, and what I'd like to do in the next few minutes is to run through some of these recommendations and why we at the Productivity Commission think that they are important. Now, our first set of end-of-life care recommendations look at the availability, funding and location of care. So we recommended that state and territory governments should increase the availability of community-based palliative care so that people with a preference to die at home can access support to do so. This recommendation included practical aspects such as identifying needs and gaps in current services, increasing the funding for and availability of community-based palliative care to fill those gaps, setting appropriate standards for end-of-life care, selecting providers, providing appropriate stewardship for services, and making sure that we have consumer protections in place. Now, there's 2 key factors that underpin this recommendation. The first is that many people prefer to minimise the time spent in hospital at the end of their lives. They have a preference to die at home. That's the term that tends to be used. During our inquiry, it became clear that the location of home and individuals' preferences about where to die can change as the end of life approaches. So dying at home really means that people prefer to spend as much time as possible at the end of their life in comfortable, familiar surroundings in the company of family and friends. Often this is the preference of both the patient and their caregivers. However, currently, for many Australians, this simply is not the reality. Reducing time spent in hospital and maximising time spent in community at end of life means appropriate health resources must be available outside the hospital setting. The patient and their carers need community-based support. Now, this includes, but is not limited to, specialist palliative care. It includes advice, coordination of care, nursing and personal care, emotional and practical care, respite care, and access to equipment. Coordination can be particularly important, both between healthcare settings and across health practitioners and services. Now, some people in some parts of Australia are already receiving this integrated community-based care, but many don't. The second rationale behind the recommendation is that the financial sums for community-based end-of-life care stack up. The core services are currently provided without charge, although individuals can top up these services at their own expense. Now, we concluded that this was appropriate and should continue. Access to high-quality community-based end-of-life care for Australians should not depend on their ability to pay. So expanding these services will require increased government funding. But this funding leads to savings elsewhere in the health system, in particular freeing up scarce and costly hospital beds. Now, there's little doubt that community-based palliative care costs less than the equivalent hospital care. The Productivity Commission reviewed the financial and annual reports for 12 not-for-profit providers of community-based palliative care. Across these organisations, the average total cost of providing community-based care ranged between $6,000 and $10,000 per person. This provided on average between 40 and 100 hours of care, delivered over a period of days or up to several months. Now, in contrast, estimates of palliative care in hospitals are above $1,500 a day, or above $10,000 per separation. Now, in this sense, funding high-quality community-based palliative care for patients in their last years of life not only benefits those patients, it represents a sensible reallocation of healthcare resources. Our second set of recommendations looked at end-of-life care in aged care facilities. Now, about half the people who need end-of-life care each year receive that care while resident in an aged care facility. But rather than being core business for these aged care services, both the services and the governments who fund them do not put sufficient emphasis on end-of-life care. For example, funding restrictions limit the duration of and access to end-of-life care in residential aged care facilities. This means that residents at the end of their lives are too often treated through expensive hospital interventions rather than being professionally cared for in the residential facility. Now, in contrast, the Productivity Commission recommended that end-of-life care is recognised as core business for residential aged care facilities. What does this mean? Residential aged care facilities will need both the funding and the skilled staff to provide appropriate end-of-life care. The benchmark is simple. The quality of end-of-life care in residential aged care should align with the quality of that care available to other Australians. Now, while easy to say, making end-of-life care core business for residential aged care facilities will involve a range of policy changes. For example, palliative care in the community is available for a patient with an end-of-life diagnosis where the individual is likely, or it would not be unexpected, if they die in the next 12 months. In contrast, specific funding for palliative care in residential aged care facilities is often limited to the last week or last few days of life. So improving end-of-life care in residential aged care facilities involves changing the way these facilities are funded for this care and the way they provide that care. The expansion of end-of-life care in both community and residential aged care facilities will only be beneficial if accompanied by a range of contemporaneous reforms. For example, patients and their carers need appropriate information and support to make decisions. This means the governments need to both collect relevant data and make that data available in easily accessible forms. Healthcare professionals need to be both trained and funded to provide guidance and support. Safeguards are needed. Individuals at the end of life are particularly vulnerable, and consumer protections need to be strong and vigorously enforced. And governments need to coordinate. In some areas, such as palliative care and aged care facilities, we observed government buck-passing and finger-pointing during our inquiry. While we can understand that sometimes governments will disagree about the lines of responsibility, those sort of disagreements don't serve the public well. Our final set of recommendations on end-of-life care involve planning. There are a range of reasons why individuals fail to plan ahead for the end of their lives. Many of us, myself included, do not want to face our own mortality. However, if end-of-life care is to reflect the preferences of the patient, then those preferences need to be known and understood. Conversations need to occur both with families and loved ones and with relevant medical professionals such as GPs. The Productivity Commission considers there are two obvious touchstones for such conversations. While end-of-life care is not only relevant for the elderly, it does make sense to introduce conversations about future care as part of normal healthcare conversations with older Australians. We recommend that such advanced care planning form part of the 75+ health check. This will require a range of reforms. First, GPs will need training to initiate such conversations. Further, often the health check will simply provide a forum for the conversation to start. The conversation will need to be ongoing, possibly involving practice nurses. These conversations will take time, and again, being in GP clinics will need some Medicare backing. A second clear point to introduce and encourage advanced care planning is when an individual enters a residential aged care facility. This will require clinically trained staff having conversations with residents about their future care needs. Again, the objective will be to develop, where the patient wishes to do so, an advanced care plan that can be used to provide guidance to healthcare professionals at the end of a patient's life. Now, of course, the final step in any advanced care planning is to ensure that the relevant healthcare professionals are aware of a patient's wishes and, where possible, follow those wishes. So what are the potential barriers to reforms? An obvious barrier is attitude and approach. For example, advanced care planning has to be based on real conversations and takes time. Unfortunately, overseas we've seen attempts to expand choice for people at the end of their lives undermined by a tick-a-box approach to planning. Choice-based reform needs a realignment of attitudes as to how patients are treated and consulted about their care. Now, I should point out that end-of-life care is not the only part of the health system that would benefit from a more patient-centric attitude. Another barrier is a trained workforce. Now, we've seen in Tasmania the relatively rapid rollout of the Hospice at Home program, utilising the expertise of community nursing. But recent experience with the NDIS sounds a note of caution about the potential to roll out new services at a too rapid rate, without allowing enough time for providers and the workforce to adapt. Finally, funding is a clear barrier. As I've already noted, increased funding for community-based end-of-life care, reducing the time spent in hospital, can actually be a win-win situation for healthcare funding. But in a federation such as Australia, it's not simply a matter of how much is funded, but also who pays. Well, of course, the answer is actually simple. At the end of the day, we, the community, the taxpayers, pay. The fights are over fiscal responsibility, and they're simply a distraction created by politicians that don't serve the community well. Now, the advantage of a Productivity Commission report is that we are a group of independent outsiders looking in. The team did not come with a preconceived agenda on human services. We're not health professionals or even specialist health economists. We are happy to draw upon a wide range of experts as possible in reaching our recommendations, and we aim to be evidence-based. But we bring the unique perspective of independence and being outsiders. Now, before commencing this inquiry, I suspect that few, if any, of the inquiry team would have expected end-of-life care to be one of the human services that we considered most required evaluation. But the evidence led us to end-of-life care. How, in an inquiry focusing on choice, could we go past an area where choice is so often neglected? The inquiry process led us to a set of recommendations that I've summarised. In our opinion, they're practical and, if implemented, will lead to a significant improvement in the lives of many Australians. Thank you. Oh, excellent.
So, thank you, Dr. King. And I'm just wondering if there's any questions. Well, I'm going to hold Dr. King hostage for a few minutes. If there's any questions that people would like to ask now. I think you've overwhelmed everybody. I think you've overwhelmed everybody. No questions now. If you think of some later, we might come back to some at the end. Liz, is that okay? If people, yeah. So, all right. I'll let you go now. Thank you so much. Thank you. Certainly a lot for us all to think about, especially the politicians in the room. I know a number of us have been working for many, many years on trying to improve certainly access to palliative care and the understanding of what palliative care is and what it isn't, and things such as end-of-life plans and things. So I know there will be lots of conversations with a number of the politicians in the room following on from this. But thank you again, Dr. King. It's now my pleasure to introduce Dr. Stephen Duckett. And Dr. Duckett's the Health Program Director of the Grattan Institute. He's Director of the Health Program, at the Grattan Institute and co-author of the Grattan Report, Dying Well. Stephen has held top operational and policy leadership positions in healthcare in Australia and Canada, including as Secretary of what is now the Commonwealth Department of Health. He has a reputation for creativity, evidence-based innovation and reform in areas ranging from the introduction of activity-based funding for hospitals to new systems of accountability for the safety of hospital care. And I think Dr. Duckett's going to talk to us about aligning policy objectives and payment designs in palliative care, so please welcome him.
Thanks very much, Senator. And I'd also like to start by acknowledging the traditional owners of the land, the Ngunnawal people, and pay my respects to elders past, present and emerging. And just remind you that when we think about access to palliative care, we need to remember that Aboriginal Australians have a life expectancy about 10 years shorter than non-Aboriginal Australians. And so when we hear that acknowledgement of country, we might like to think about what the consequences are for us and our work in palliative care, for example, of that difference in life expectancy. So I'm going to talk a bit about funding arrangements, building on what Stephen has just said, and partly drawing on a report we did a couple of years ago called Dying Well, and partly a recent paper that grew out of that, which looked more directly at funding arrangements. One of the things I've done over the last 12 months is read all of the submissions made by individuals to the Victorian Parliamentary inquiry into end-of-life care. This is not something you can do in one sitting. I could do at most 5 or 10 a day, because some of them are extraordinarily harrowing. They talk about the failures of the palliative care system in all sorts of different ways. They talk about problems of access in particular. Here's one who couldn't get access because they don't class his condition as terminal, even though there's nothing his surgeons can do for him. Here's another one where a particular palliative care service refused to give them treatment because he wasn't going to be dead in 3 months. And so we have all sorts of constraints on access to palliative care today. On the other hand, we had good stories as well, that the palliative care was working and it really made the end-of-life experience one which happened in a way that the family was good for the family as well. So I started to think about what are the consequences of all this. And I also started to think about what are the values that ought to be underpinning our policies in palliative care. And obviously, one of them is the standard sort of policy about, or set of values about compassion, about ensuring that we look after for people who are in need, who need our support. Another one, which I'm not entirely sure is an underlying value, or some might, is about autonomy. It might actually not. It might be an attribute of providing a good service. Certainly another one of our underpinning values might be something about social justice and equity, that we want to make sure that everybody has access to a service and that people without with lower incomes or in rural Australia or disadvantaged in any way have the same access or at least comparable access. And finally, we want to have an economy that helps us survive, or that the economy survives over time. We ought to actually make sure we've got a responsible use of resources. So, you know, it's all very well to talk about values, but I think it is important to talk about values because it sets the scene for how we ought to shape the policies, how we ought to shape what we're doing about policy and funding arrangements. And those values ought to underpin a more prescriptive or more sharply defined policy goals. And so, for example, a value of compassion ought to underline a policy, ought to lead to a policy goal, which is about ensuring access to care. But it also ought to lead to a policy goal, which is about making sure the care that people have access to is of decent quality. And so you ought to be saying something about quality provision. And of course, there's an interaction between access and quality as well. And another aspect, possibly an aspect of quality or possibly stemming from a value about autonomy, is the issue of patient choice of location of death, which Stephen talked about and which the Productivity Commission reviewed. And of course, as I said, I think patient choice of location of death is to some extent simply another aspect of quality provision. If we're talking about social justice and equity, we want to think about minimising financial barriers to access so that the costs of palliative care do not inhibit access. And again, if you read those submissions to the Victorian Committee, you can see stories about where cost was an inhibitor. And finally, if you're serious about responsible use of resources, you also have to talk about efficiency. And I know sometimes in the healthcare sector we don't want to talk about efficiency, but we have to actually be able to say that what we're doing is efficient. And as Stephen also pointed out, the evidence is that palliative care in fact saves money. I'm on a body in South Australia called the Health Performance Council, and we did a review for the then Minister for Health which looked at palliative care in South Australia, and what we showed was that those people who had access to palliative care as recorded in their healthcare record or in various different ways actually had reduced utilisation of intensive care units, for example. What we know from overseas, though, from overseas studies and the study that's being conducted in Australia, is that people who have early access to palliative care have a longer life expectancy. So we're not achieving efficiency at the expense of life expectancy. What we are doing is achieving efficiency at the expense of using resources which aren't contributing to life expectancy. And again, it's all very well to have these broad policy goals because everybody can probably sign up to what's on that PowerPoint already. It's then the actual operationalisation of that which actually makes a difference and which is particularly important. And my view is that if we are to achieve efficiency, we have to actually fund palliative care on the basis of activity-based funding. That is, on the basis of what they do rather than anything else. And why did I come to this view? Well, for example, in Victoria, community-based palliative care organisations are funded on the basis of a population. And when you think about it, what incentive does that provide to that palliative care organisation? It provides no incentive to that palliative care organisation to reach out to hard-to-reach communities to actually encourage them to use those palliative care services. It provides no incentive to actually provide additional services to actually do any outreach whatsoever. On the other hand, if you walk across the divide and go to a public hospital, they are funded on the basis of activity-based funding, but up to a cap. Now, in a sense, that cap is for the whole hospital. In fact, the cap is for the whole state. In fact, the cap is for the whole country. But nevertheless, they're provided more or less, in the case of palliative care, unlimited, uncapped funding. So what we've got in Victoria is a specific policy objective to encourage people to have palliative care in hospital. That's probably not the way they describe it, but that's the way it actually works given their funding design. So I thought, maybe we ought to have activity-based funding applying across the system, but as I've said there, at the national efficient price, which means we don't say to everybody what you're funding, whatever you like to be funded, and so on. And I've also said the funding should be uncapped. So it's effectively uncapped in public hospitals. I'm suggesting it ought to be effectively uncapped in the community. Now, how can I stand up and say that and also have up there responsible use of resources and efficiency? I have talked about palliative care and end-of-life care to any number of people, and I've not had very many of them say, look, I'm 25 and I'd like to use palliative care now, thank you very much, even though I'm perfectly healthy. Phrased differently, the moral hazard associated with uncapping the funding is very limited, because essentially palliative care is for people who are dying in the foreseeable future, be it 12 months, 3 months or 30 days. And so what you could say is palliative care need is essentially naturally capped by the number of deaths. The question is what amount of resources goes into that number of deaths, and I'll come back to that. But essentially I think the risk to government or the risk to taxpayer of uncapping funding in these circumstances is trivially small. Bearing in mind it's not the only healthcare funding which is uncapped. So, for example, the MBS is effectively uncapped. The PBS, subject to an efficiency threshold to get access to the PBS, is essentially uncapped. So the concept of uncapped funding is not an anomaly in the healthcare sector, and my view is if we're serious about palliative care, we ought to be serious about uncapping the funding. So funding is not the barrier to access. I just might mention here, even though Stephen avoided this question, the story about the United Nations High Commission on the Elephant, where they established a commission and the South Africans produced a paper called The Elephant and Imperialism and The Elephant and Racism. The Americans produced a paper which is How Capitalism Can Save the Elephant, and the Swedes produced a paper on the elephant and sex, and the Australians produced a paper, The Elephant, a Commonwealth or State Issue. So what we're talking about here is who should be responsible for funding. I agree with Stephen, it's a secondary issue, but my view is the Commonwealth should take responsibility, and I'm happy to talk about that further, but essentially they're responsible for residential aged care services. Essentially they're responsible for a number of other related services, aged care services generally in both states. And so it seems to me that it's not inappropriate that they extend the same policy responsibility across into palliative care, but it's not an essential element of what I have to say. If we're serious about quality, then in our policies we ought to have something serious about performance. And Mike is going to talk later about metrics and so on. Suffice it to say that it is also one of the ways of dealing with some of the risks of uncapped funding. So, for example, you might have a performance indicator that says that, say, 80% of the funding that you receive needs to be spent on someone within 3 months of death or something like that, recognising that spending on palliative care can occur way before that, and so you don't say 100%. But anyway, so you actually start to build in to your arrangements something serious about quality provision, and also that begins to signal what government thinks is serious about what they think they're trying to achieve with palliative care. Similarly, patient choice of location of death. You might actually begin to ask patients towards the end where they want to die, what proportion of, and ask families, did the patient end up dying where they wanted to die, which may actually be in hospital, but it may be in hospital only for 1 day or whatever. finally, you ought to have serious limits on out-of-pocket costs to ensure that there are no financial barriers to access. So anyway, what I've put there, which is outlined in a paper I published earlier this year, is a framework for thinking about where we ought to be going in palliative care, which translates our broad general aspirations, our values, into specific policy objectives. And that's one of the things I noticed in the Victorian debate on end-of-life care. Everybody was able to sign up to, yes, we love palliative care and we want to give it a big hug, but no one was prepared to say, what are we going to do precisely to make it accessible to everybody when they need it? Thank you very much.
Thanks, Dr. Duckett. Can I say, when you had the elephants up there, I thought you were going to say elephant what elephant for Australia, because it's still a conversation that too many people don't have and don't want to participate in, or either, just don't mention the elephant in the room. So have we got any questions for Dr. Duckett at the moment, or do people want to hold off till the end, or has he also wowed you all so much that you need to take it in a bit? I think you're off the hook for the moment. Thank you again. It's now my pleasure to introduce Professor Mike Woods. Professor Woods is of the Health Economics at the Centre for Health Economics Research and Evaluation, called SHARE, at the UTS, and a visiting scholar at ANU. He's also the independent reviewer for the COAG Health Council review of the accreditation system for health workforce education. Mike is currently supervising research into developing a palliative care performance framework. Mike's had a long career in economics and public finance in the Commonwealth and the two territory governments. He was Deputy Chair of the Australian Productivity Commission, presiding on over 20 national policy inquiries, including Australia's health workforce and caring for older Australians. He was previously the Under-Treasurer for the ACT and a member of the Australian Statistical Advisory Board. Mike has held appointments with the OECD and the World Bank, and has worked closely with national ministries in China and Vietnam on economic and fiscal reform. Mike is also a Fellow of the Royal Society of New South Wales and a member of the Centre for Strategy and Governance. After all of that, could I say welcome and thank you.
Apologies for that. I must take more attention to what's said. So I too would like to acknowledge the traditional owners of this land, the Ngunnawal people, and pay my respects to elders past, present and emerging. And thank you, Senator, and to other members and senators. And we have exceedingly a full house. We have packed to the edges. So that's excellent for the work that you do as the Friends of, and for the respect that Palliative Care Australia has in this space. So congratulations. So we've had the PC report that Stephen did, and my earlier report, Caring for Older Australians, made a very strong link between aged care and palliative care. In fact, I ran into some serious debate on whether we should include reference to palliative care and end-of-life care when I was doing that Caring for Older Australians report, and I just could not get through to people as adequately as I would wish that the two are so totally intertwined, so completely interlinked, that clearly you needed to have a broader debate. And Jane, in your introductory remarks, you made reference to the different streams and systems we have. We have the aged care system, and we have the palliative care system, and we have a disability system and the like. And it's time that we change the public narrative to look at the question of ageing as such. Now, palliative care and end-of-life care also deals with a whole lot of age groups, but if I can just, for this part of the conversation, reflect on the older community, and that it would be much better to have the debate about ageing, and people have different needs and need to call on society to different degrees in that ageing process, and it's not linear. People have different needs at different times, but not necessarily linear trajectories. So I think we all need to reframe our systems into that broader discussion, and I intend to do my little bit in that space. So we've got the big question, how good, how sound, how robust is the palliative care delivery that we have, and what is the distribution of that, and what's the level of care, and who provides it, and where's it provided. And we've got some partial evidence, and that keeps accumulating. So we know things about diagnoses. So if you have a cancer diagnosis or malignancy diagnosis, more generally, you're heading through a particular palliative care trajectory. And we know stuff about location, and Stephen Duckett's other work that he didn't mention, but the perils of place show up those issues very strongly, that it depends in part on where you live as to what quality care you get. Whether you're in acute care, if you're in a hospice or hospital versus in residential care or at the home, cultural and linguistic issues and all the rest of it. So we've got bits of evidence, and those bits of evidence keep accumulating as earnest researchers and others work through that data and produce papers and keep reinforcing those. But they are literally bits of knowledge here and there. We don't have a total framework, which is where I want to get to. So we need to understand how can we pull the data together that is relevant to policy and relevant to delivery. So I don't mean nice academic papers that go in A-star journals that no one reads. I mean relevant data of high integrity and high quality, stuff that's comprehensive, so it actually spans the broad range of needs, and that it's timely. We suffered desperately in terms of lack of timeliness in data. It takes so long to get compiled, and then so long to be analysed before it's actually published and usable. So our requirement from Palliative Care Australia is to say, create a framework in which all of this evidence can operate. Now, such a framework really needs two perspectives. It needs a functional perspective, and this is where Stephen Duckett's policy column comes in very strongly, where the Productivity Commission's work, which is all about, well, let's get the evidence, but for what end? What do we want to do with that? What can we recommend from it? What policy change can be made from it? And it needs a spatial framework. Where does it occur? How is it occurring? How is it distributed? So our challenge has been to develop a functional framework and a spatial framework. They're the sort of organising principles for the data. Now, this is sort of first work at developing a functional framework, and what we did was we went and looked at what the OECD does, because the OECD synthesises data from whole ranges of countries and tries to put them into a general organising principle. But we also went to the Productivity Commission, and I have 18 years of background in the Productivity Commission and used to supervise the Blue Book, as people fondly know it, or the Report on Government Services, as it's more correctly known. So I love that document to death. And importantly, when it comes out every year, it creates media and attention and focus and things, which I'll get back to in a minute. So we looked at what the PC does in its Blue Book. It doesn't deal with PAL care specifically, but it does with community health and hospitals and several other areas. And we looked at what the OECD does. And we've sort of come up as a first position to develop and the concepts, the efficiency, equity and effectiveness. The performance goals, you'll notice those sort of have some similarity where Stephen Duckett was heading in terms of his policy column. There's no point measuring stuff if you're not going to use it, if it's not relevant to either the deliverers of care or the policy makers who try and create the frameworks in which that delivery is provided. And then we're starting to say, all right, how would you measure that performance? You can have a copy, Stephen, you don't need to take photos. So anybody, don't bother writing stuff down, we'll just make sure that all this is available. With the only caveat being, this isn't the end of the journey, this is the front end. We're just exposing it and looking forward to commentary from you. But equity issues, so the access, the financial that Stephen talked about, the cultural, linguistic and other barriers to care, the regional access issues, the perils of place and those sorts of concerns. In terms of effectiveness, if you do have a diagnosis on malignancy, you have a particular pathway. Your table's here, Andrew.
Oh, that's all right. Sit back here. Thanks, mate.
No, that's probably where you belong. Okay. Lovely to see you, Andrew. He's my MP. I love him dearly. But if it's dementia or if it's end-stage renal failure or others, then the pathway through to palliative care and end-of-life care is a lot more problematic. So that's an access issue. What your diagnosis is at the front end. Timeliness of service. So are you getting it when you need it? End of life is not something that waits for the system to catch up with you. That trajectory is happening. What is the quality of that trajectory that is important? And that's why palliative care timeliness is absolutely fundamental in that space. Having advanced care plans, having carer services. So they're access issues. If the carer isn't being serviced, then it becomes harder for them to help the person who needs the palliative care to receive and benefit from that palliative care. Appropriateness. Now, obviously, symptom control. First thing is we're dealing with a whole range of symptoms, some of which are medical, some of which are psychosocial and the like. But are the symptoms under control? Is it culturally appropriate? Is the workforce capable of delivering it? And is the surrounding life environment in which you are operating? So if you particularly want to be in home care, if nobody's looking after the activities of daily living to support you in that, well, you end up in hospital anyway, even if that's not your choice. So you have to think holistically about the appropriateness of the care being delivered. Safety issues, so is there a risk management for adverse events? Is there medication management? Because at this stage of life, polypharmacy can be a huge issue. And if it's not addressed properly, then we're not providing the appropriate care. Responsiveness. And again, both Stephens were talking about consumer choice. I mean, that was the essence of your whole report. And Stephen, you were talking about the appropriateness of care for the patient and for the carers, I would add. Continuity issues, including the electronic health record, and efficiency issues. I am an ex-under-treasurer for the ACT and also worked at the Commonwealth. I believe in the taxpayer, and the taxpayer deserves to have its funds spent in a most efficient manner that achieves the outcomes that have good, solid policy goals. So I'm, like my previous two speakers, am very committed to efficiency. Okay, so that's the functional framework that we're developing, and that will no doubt change as more informed people than Siobhan and I develop. So we're looking forward to all of that feedback and iteration. But then we need a spatial framework. So we've come up with those as well, because there are more of them than there are of states and territories, and there are less of them than there are of local governments. And whether it's 31 of these or 62 of something else or something, but we need something in that space. And so we're using PHNs not because we want this to be a new additional burden on PHNs themselves to have to do something, but as the spatial organising framework within which we fill in the data so that we can have some spatial representation of what is happening across the country. So PHNs would be a contributor to it, but the AIHW and the local health districts and anyone else who is part of that total process would feed their data in, and we will use the PHNs as the spatial framework, but not just here's another thing that PHNs themselves have to do. And I've identified two there because we are working very closely with them and their LHDs and other organisations to build up pictures of this. So why PHNs? They are an existing geographical organising framework that sort of is, as I say, sort of in between two spectrums that don't add too much value. Importantly, PHNs have a framework that focuses not just on acute care, and there's a lot of palliative care that is all about acute care, hospitals, hospices, etc., whereas we want to make sure that the discussion is all about the broader delivery of palliative care to people. So it's got to have a primary care focus very much, as well as an acute care focus. So PHNs are a good framework for creating that narrative, that this is about people's lives wherever they may be. It allows us to have a benchmark of performance. So we can benchmark 31. We can also benchmark over time what each one is doing over time and what each one is doing relative to others over time. So that benchmarking is a really, that to me, and Liz keeps sort of hammering that point. This is fundamental to ensuring that we understand what progress is being made, where we're at and where we're heading and why we're heading there. A biennial update, so that every 2 years there is a big policy debate and a refocus that says this is coming out, this is being published, where are we at now, what's happening? And it just is a mechanism to keep palliative care, end-of-life care in the public mind. And the media love these things. Every time the Blue Book comes out, and I used to be sort of locked away for a week answering some good questions and some, I have to say, inane questions, but nonetheless, it got lots of media and it got mentioned in Senate estimates and all sorts of places. It's a great way of making sure that debate is ongoing. And it will assist PHNs in their own needs assessments because it is a support to them, not just something to be done by them. Now, there is a lot of work being done in the PHN space. So AIHW, you can go into there and you can generate reports of a lot of their data on a PHN framework. This is an example of the HPV virus and immunisation for girls. And there's a lot of data there, but you can go into one PHN, you can go into Murray, and you can build up a picture of a whole lot of AIHW data on that one PHN, or you can look at it across and say, all right, where are all PHNs in this thing? So we are starting to establish PHNs as a useful basis for doing this. So our next steps are then to start saying, well, what are the indicative measurement indicators? And I won't go through these, but we're starting to build up how can you start to find measures for each of those performance indicators. Now, the Blue Book, the PC's Blue Book, is a very good model because it has got some indicators that are totally white, which says this would be a really great indicator, but there is no data. Pity about that. It would be really good to have data on this, but we're still going to publish it. We're going to say this is the data we need, even though it doesn't yet exist. And then they have slightly shaded ones that says, well, there's a bit of data, but it's really not very good. Then there's a darker shaded boxes that say, this is data about one aspect of this performance indicator. And then there's fully coloured box that says, hey, this is good data, high integrity, timely and comprehensive. But it doesn't mean you only publish those. You publish the whole lot of them and then identify where the gaps are, because by showing where the gaps are gives you the challenge of where to head to. So, yeah, I've got, this will be available to anybody who wants it, but, you know, we're starting to build out what would be the data we want, and then we can work out, have we got that data? Is it any good? Is it timely? Is it comprehensive? What's its integrity, etc. So this is just to demonstrate to you that this is where we're heading. I've got government expenditure down there. That's got nothing to do with efficiency. That's just how much is spent. Efficiency is above the line there because that's the really key thing. But we still need to know how much public money is spent, because at the very front one we had how much private money is spent, and we need to put the two together. So our next steps are, we're working with Murray and Sydney North. They're two totally different PHNs, and with their LHDs and with the AIHW and others to build up pictures. Once we do that, that's helping us refine the framework. Then we would like to have some workshops on that framework around the nation to understand what all that represents. We'd then like to run out to, say, another 6 or so PHNs. And I have to say, last night I got a 9-page document from a very excited Brisbane North PHN who said, hey, we're not waiting, you know, we're in this, and here's our 9 pages of submission anyway, you know, take it or leave it, but we're doing it. So there's a lot of interest, a lot of excitement out there in that space. Then ultimately we'd like to end up with a national performance framework that gets published every 2 years. But that's where we're heading, but we're starting at the start. Thank you very much. I'll assume that nobody wants it.
I'm not going to hold Professor Woods hostage, but does anyone have any questions at the minute? It is great to see movement in the area, and can I thank you on behalf of everyone for your presentation today. Now, we're doing quite well time-wise today, but we still have one guest speaker. So we're going to hear now from Professor Anna Barker, Head of Member Health Innovations from Medibank. Anna leads the design of new services that aim to improve the health and healthcare experience of Medibank customers. This includes the Medibank at Home program that includes rehabilitation, chemotherapy, palliative care and dialysis services. She's a physiotherapist and experienced health services researcher, having previously been the head of the Health Services Researchers Unit at Monash University, and therefore has a keen interest in ensuring services are evidence-based and conducting evaluations to confirm they are achieving intended impacts. So please welcome Professor Anna Barker.
Well, first of all, I'd like to say thank you very much for Palliative Care Australia for inviting me to present here today. I actually feel very privileged to be part of this very important debate. I have some very impressive presentations previously, and I will try to live up to the expectations of sort of delivering a similar value in the presentation that I'll present to you. So I'm here today to talk to you about a trial that we have been funding at Medibank to deliver palliative care in the home. The data that I'm presenting to you is a snapshot. By no means is it a full evaluation. You'll see from some of the numbers in the presentation, we don't have an incredibly large sample size, but despite that, I think there are some really valuable learnings that we have from the information that I'll present. And it's been very reassuring to hear some consistent themes about quality of care, about the importance of measurement, about the importance of ensuring equity of access, and all of those things are things that we prioritise at Medibank in terms of palliative care in the home. So I like to give you all of the information on the first slide. So if you only watch this slide, you'll get it all. So feel free to tune out after that. So I think it's been highlighted by others that really palliative care in the hospital system, which is how we can measure palliative care most easily in Australia, whether or not you're in public or private, is growing in terms of volume. And its growth is faster than other areas of hospitalisations. We know that there is a good body of evidence that really supports palliative care in the home, in that it enables people to be more likely to die in their place of preference and also to access hospitals less frequently than if they did not receive palliative care in the home services. So based on this evidence base and this knowledge, and to be honest, the growth of palliative care programs that were happening in a public setting, I think Medibank felt very committed to ensuring that its private members had similar opportunities in terms of access to palliative care programs, and that we could really support those activities that were going on in the public setting. So in 2016, in November, we commenced a pilot or a trial palliative care in the home service in Perth in Western Australia. So when we initiate a pilot as a private health insurer, there is a geographic restriction on where the service is delivered. And this was largely based on the service provider availability and capacity. So we'd identified a quality provider in terms of palliative care in the home services, and we were able to then partner with them to enable Medibank members in that area to access palliative care in the home when that was their preference. So I took as recent a snapshot of data that I could get for you, and that was data of 66 Medibank customers that had enrolled in the palliative care at home service, and that was current as of the 30th of June this year. The average age of those participants was 72 years, and 85% had a diagnosis of cancer. And we've heard some of the other speakers talk about malignant diagnoses and cancer being a very common and established pathway in terms of accessing palliative care services. One of the things that we sought to do when we were looking at palliative care in the home was to try and also capture some of the benefits to the member in terms of an economic perspective. And that might sound rather strange, but we know that there's actually a burden for members and their family, in particular and their carers, when they are travelling in and out of hospital to then receive services, and that there are costs associated with that, even if those costs are small and just related to simple things like parking, and we all know about out-of-pocket expenses that unfortunately do occur with private health insurance. I'm very proud to say that of those members that have died in the palliative care at home service, 8 out of 10 died out of hospital, which is a pretty good statistic in terms of really reflecting people dying in their place of preference. We also see that the hospital utilisation in their final 3 months of life was lower than what we see in those that receive palliative care in the hospital in our Medibank data. On average, customers that participated in the palliative care at home service received 68 occasions of service, and as you'll see from the subsequent slides, I'll detail a little bit of the services that were included in the palliative care at home program, and an average of 75 hours of service throughout their palliative care in the home admission. So many people in the audience will be quite familiar with this information, and it's no surprise in terms of some of the research evidence that really supports and values people's preferences in terms of place of death. We know that between 60 to 70% of Australians would prefer to die at home, yet only 54% die in hospitals and only 14% at home. What we have with the Medibank at home palliative care program is that member that lives in the geographic area might self-select to participate in the service and then contact us to be put in contact with the service provider, or their doctor that is providing their care may refer them into the service. That's referral is then considered by the service provider to ensure whether or not the care can be appropriately and safely and effectively delivered in the home, and developing a then personalised care plan for those that are admitted into the service. We know from the speakers previously have highlighted the utilisation of hospitals in the final 3 months of life. And some data that we have from Medibank in our own members show that up to 21% of their last 3 months of life, the time and in days, is spent in hospital. So 1 in 5 days spent in hospital. And during this time, we can see from our claims data that many people receive quite intensive interventions, such as intensive care, dialysis, radiation therapy and life support. And I think we need to be careful to say that these services are not or shouldn't be excluded for those receiving palliative care, but I think it sort of highlights that there is probably opportunities in terms of efficiency and appropriateness of care that we can try to ensure that people have appropriate support in their end-of-life journey. We see on average in the final 3 months of life for those that are coded as receiving palliative care and in a hospital, in Medibank data, that on average they spend 16 days in hospital, and that on average they live 56 kilometres from hospital. So that sort of talks to this point about the burden of travel, of frequent visits in and out of hospital for both the individual and also their family and support network. So the palliative care trial service that we are funding at Medibank is a patient-centred model that really aims to deliver a tailored program for individuals in their home. It is a coordinated program that incorporates medical governance and is led by a clinical nurse case coordinator who works very closely with the individual, their family, to partner with them to identify what their care needs are and trying to support them to then remain at home in their end-of-life journey. So it's a multidisciplinary program. I would consider this a high-quality program in terms of the multidisciplinary nature of the program. I think another strength of the program is that it aims to partner with people that have a life expectancy of 3 months or less. I'd like to see that increase. I'd like to see that we really are able to partner with people earlier in that journey to establish those relationships, really get good understandings about their care needs, and that really I'd like to see that move from 3 months to 6 months to 12 months in terms of quite a holistic care model. It incorporates nursing, allied health, domestic assistance, equipment and consumables. So really it's intended to be an all-inclusive wraparound service for the customer and their family, and to really try and minimise, if not eliminate, any out-of-pocket expenses that they may incur. So as I mentioned previously, the average age of the participants is around 72 years, with 90% aged over 60 years. And we do see that there are a range of diagnoses that people have in terms of that have led them to receive palliative care. You see on the graph down the bottom, it is just a count of people that have hospital days during their palliative care at home admission, and you see it's really variable. And I think that that's okay. There are people, a large number of people that have no admissions to hospital, and I think that's fantastic. There is a number of people that then do have some hospital days there. I really would like to see that we are able to flex and tailor our services more, maybe increase small things like personal care support in critical times when the family need it, in a very timely approach when they are really needing a break that might be able to prevent and minimise some of those hospitalisations. We see that over 14 hospitals have referred into the service and over 15 medical specialists. And for the sample size of 66, I'd consider that that's a good indication or indicator of acceptability of the model of care where it's being delivered over in Perth. So we did see that 67% of those that have passed away died at home. 13% died in a palliative or an aged care facility and 20% in hospital. So in terms of the Medibank funded palliative care in the home service, I think that it really provides a unique opportunity for customers to spend more time with their family and friends in the privacy of their own home and surroundings, while still receiving 24-hour access to specialised equipment and staff. There have been no complaints or clinical incidents that we have received, so in terms of indications that we have of safety of the service, so far it's looking very positive. 8 out of 10 people enrolled in this service did not die in hospital, and that's a statistic that with our service provider we're very proud of. Palliative care at home, as I identified, we believe also contributes an economic benefit to the member and their family in terms of reduced travel expenses and costs. And we also know that customers spend considerably less time in hospital for subsequent admissions than a typical inpatient palliative care customer in the 3 months prior to death. Despite these positive findings and really a good news story from what I can see so far, I think there's much opportunity. In terms of equity of access, we have Medibank members that are not just in the Murray PHN catchment or the inner Sydney. We have members, 3.8 million of them across Australia. I think we're pretty optimally positioned, therefore, to really support others here in this room to drive a national model in terms of palliative care. And we are committed to really working with service providers out there in the community, government and other organisations such as Palliative Care Australia to see how we can do better in this space. I think one of the key points that I noticed from the data so far is I think that whilst the service is doing a great job at supporting customers and their family in the home, I'd say that there's still opportunity to improve that capacity to be able to flex up in certain services at critical points in time to really enable people to stay at home when that is their preference. I think we have an absence of data on patient-reported outcomes and patient experience measures in this space, and I would really welcome partnering with individuals in terms of identifying what are the best measures that we can use in this space, and as Medibank trying to ensure that we support the collection of that data that enables us to really identify where there's opportunities to improve the service and how we are doing in terms of the delivery. And as I mentioned previously, I think that whilst we have an average length of stay in the program of almost 3 months, I think there's opportunity to really extend that partnership with people in their end-of-life journey. Thank you.
Thanks, Anne. Some really interesting work happening there, and I'm wondering if there's plans to expand that program at the moment.
There absolutely is. So we have just embarked on a new 2-year pilot, and we are out there. I think I've had in the last month meetings with 4 or 5 different service providers out there in the community to talk about how we can try and develop a model that is standardised yet tailored and flexible to those individual service provider capacities and specialties. So definitely our intention is to be able to try and expand this program geographically and also within the types of people that access the program as well.
Thank you. Any other questions for Anne at the moment? I'm sure later on there might be. Can I just, before I thank all our speakers, can I just also once again acknowledge that my co-convener, Nola Marino, who's up there grabbing a quick cup of tea while she can. I did acknowledge you before, Nola, and passed on your apologies and said you would get here when you could, so people understand the comings and goings of all the politicians in the building. But look, it's my great pleasure to, firstly, can I just thank all the guest speakers. Really a lot of thoughtful information gone into the presentations. I think I often leave these events with Power Care, and then the next day it starts to sink in a bit with me. Maybe I'm a slow learner, I don't know, but it takes a while. There's a few other things going on through the rest of the day, as you can understand. But some really thoughtful, well thought out future directions I think we should be looking at. And I'm sure that if you have, a chance to talk to some of the politicians in the room, there'll be a lot of support for the ideas you put forward. But it is now my great pleasure to introduce Liz, the CEO of Palliative Care, and I think she's going to wind up. I'm not sure. What are you doing, Liz? I'm not sure. Sorry. Oh, have I? No. Well, I'd hate to, steal your thunder, but anyway, I think everybody in the room knows Liz.
Yes, they do.
And so I'll hand over to Liz.
Thank you.
Thanks, Liz.
And thanks, Nola, for making it. Yes, so I am just going to wind up. I want to thank all of the speakers. Thanks for making the time to come. Nola, for your benefit, I'm just going to quickly recap on what the speakers have said, but I think it's worthwhile just emphasising a couple of the points. Stephen spoke or gave us a comprehensive account of the Productivity Commission report and talked about a range of issues. I was really impressed about your recommendations around advanced care planning, and we've got Karen Dettering here today, Head of Advanced Care Planning Australia. We'd be very pleased to hear some of your recommendations there, and I think exploring that further as part of choice-based reform is really important. And of course, your end-of-life care as core business for aged care is very important, and I think neglected at the beginning to welcome members of the LDAC partnership group here today, which is the end-of-life directions in aged care, a significant investment by the Commonwealth Government looking at that interface issue between palliative care and aged care and advanced care planning. So we have a big roundtable tomorrow to talk about funding, so Mike Woods is involved in that as well, so that's really good. Stephen Duckett, thanks, Stephen. You did a great presentation talking about directions of for funding design in PAL Care, and I really liked the fact that it was underpinned by a set of values, and I think that's something that we can take forward and keep thinking about that in terms of policy goals and appropriate funding design. And Mike, you gave us a very comprehensive presentation on, I guess, talking about the importance of pulling together timely data and to assess unmet need across the country. And you're right, that is one of my bugbears. I feel that we don't have the same level of care, or we know that we don't. It's not accessed equitably across the country, and we need to just understand that better in order to have a response to that, I think. And Anna, thank you. We've had a couple of conversations now, and really impressed with the work that you're doing and with your trial. And I think you're right, there are lots of opportunities to explore appropriate care in the end of life, and I was really taken with your slide. It's not different to anything I've heard, but the increased use of resources at the end of life, particularly intensive care, that type of thing, we really need to sort of look at that. But so that's all. I just want to thank everyone for coming, and thank you all for taking the time to come. Thank, of course, the staff at PCA for pulling this together. Another great job. We're going to convene and meet here again in October and have a focus on Aboriginal and Torres Strait Islander palliative care, but you're all most welcome to attend again. And thank you. We do appreciate your support, and thank you, Katrina and Nola, again for supporting the work of Palliative Care Australia. Thank you.